Assalamu alaikum and good evening, dear physicians. After a long hiatus, we have again started our program from ECG study group, that's ECG Basic and Beyond. And today, our topic of lecture discussion is fundamentals of electrocardiography. And speaker of today's session is none other than our beloved and respected Dr. Rafique Ahmed sir. Before start of the lecture, I like to request Professor Abdul sir to say a few words regarding Rafique Ahmed sir, and then we proceed. Abdul sir.
Assalamu alaikum. Good evening to everybody. Rafique sir is well known to us. Nothing to mention much about him. He's a great teacher, and I always say he knows how to make a complex thing very simpler to understand. And when we started electrophysiology, he was a great support to us, and we learned so many things from him, especially Atahar Ali, myself, Sadi bhai. We used to attend his workshop at NICVD. He used to come twice yearly to teach us electrophysiology. And now we are doing electrophysiology ourselves. And we also learned many simple things which makes an ECG complex, but he makes it easy. And we learned a lot of things from him. We are grateful to him. Let's listen to his talk. Sir.
Yeah. Thank you, Jamil, for the kind introduction. Welcome back after a gap, which was necessary for us to do. And I see a good number of participants today. I'm happy about it. Let me see. Oh, let me having little problems. Can you see my screen?
Yes, sir.
Okay.
Yes, sir.
Yeah. So what I did today, because this is the first lecture, I thought that we'll do some basic stuff. And these are the things where I tell people that, look, listen to this, try to remember things, and then if it stays somewhere in your brain, when time comes, you can look up the book and review it. And it's necessary to review it from time to time. This is the heart. It's actually says the chest has been open for most probably some kind of cardiac surgery. And you can see that this is the right atrial appendage. And most of this is the LAD where it should be. This is the fat that's going on. This is the right ventricle. This is the left ventricle. This is the aorta. And this is the pulmonary artery going. That's the concept. It is important to remember the anatomy from time to time, because we look at the chest. A lot of times we don't think where each chamber is. So if this is made into a okay, so this is the diagram of the same heart. So you can see that this is the left atrial descending artery going here. Right ventricle is up to here. It overlaps in the front, unless it is rotated. So aorta, right coronary artery, left main, left anterior descending coronary artery, and right coronary, left circumflex. And this is the right atrium. So if we open the heart, this is a diagrammatic representation. So we have this sinus node, which is at the junction of right atrium and superior vena cava, AV node, and then bundle branches. And as you can see, there has been drawn some connections between these, and these are called sino-nodal connections. But these connections are not histologically or electrophysiologically proven. This is we think that there are some preferential conductions, but we have never been able to prove it by any means. And so I'm going to skip this one. So if you open up the heart from the right side, you can see that the sinus node is located at the junction of superior vena cava, right atrium. It is not a small dot the way we normally draw it. It is a long structure. It's about 1 inch long. That means 2.5 centimeter long structure. And then we have the AV node, and this is the right bundle, which comes down, goes through the moderator band to the lateral wall of the right ventricle. And that's why when we do catheterization, sometimes we can bump into this and cause the right band. This is fairly superficial on this side. And on the left side, left bundle is a little bigger. It's a wider structure. It's flat, and then it goes into left anterior fascicle, left posterior fascicle, and then it distributes. And you can see it is actually subendocardial, all these structures. And these are the structures that conduct the electricity very fast through the both ventricles, and within a period of about 80 milliseconds, just the duration of the QRS complex. And if this conduction system is disrupted, the QRS becomes wide. So this is, you can see that on a specimen, you can see this faint streaks. This is where the left bundle is, and it has been drawn here. So histologically, you can find it with dissection. The AV node, this is the right atrium, and little difficult to understand, but this is where the inferior vena cava is. This is coronary sinus. This is tricuspid valve. This is the superior vena cava. This is right atrial appendage, and this is fossa ovalis. And the AV node is somewhere here. And why it's important for us, especially as people who do electrophysiology study, that we use the coronary sinus as a landmark, and then we think that the AV node is somewhere here. And this is how it's, again, if we look at the picture again, that this is the coronary sinus, this is tendon of Tushar, and this is where the AV node is. Even though AV node has been drawn as a complex structure, it is not. It is actually, there are branches, it's like a tree root. And this is where the area of slow pathway is, and this is the AV node fast pathway. And this is important because that's how we get AV node reentrant tachycardia, and this is the tricuspid valve. If any of the audience have problem, please stop me. I want to go slow because unless you look at it carefully, it's difficult to get confused with the orientation. This is the inferior vena cava. So again, coronary sinus, tricuspid valve, this trigon on the top is the AV node, and this goes to the bundle, his bundle, and then bundle branches. So as you can see, it goes upward a little bit and then goes down. And as it goes upward, we are closer to the aortic valve. And that's why when people go for aortic valve surgery, sometimes this conduction system can be damaged and patient can develop heart block. Same thing happens with TAVR procedure, that we get about 10 to 14% incidence of heart block because this conduction system is passing close to the vertebra, and the pressure and the mechanical things. So also patients with aortic stenosis get fibrosis, and this conduction system can be damaged more often in patients with aortic stenosis than other valvular disease. This is again just anatomy. If you look from the bottom, this is the left ventricle, this is the mitral valve, tricuspid valve, and as you can see that mitral valve, and then there is this papillary muscle and tendons which is holding the valve. These muscles are very important anatomically, functional wise, also electrically sometimes they can produce arrhythmia. And this is a longitudinal section of the left ventricle. As you can see, this is the papillary muscle, and then this trabeculae connecting to the valves and holding it and preventing it from prolapsing into the left atrium. And this is the left atrium. This is one of the coronary arteries and probably the coronary sinus. Again, another section, left ventricle and the right ventricle. Right ventricle, as you can see, is much thinner structure compared to the left ventricle. And so when we put catheters and stuff in, there is more likely to perforate than the left ventricle itself. So if we look at the junction, it's interesting. This is important for electrophysiology. This is the left side, left atrium and the left ventricle junction. It comes down and it connects to the ventricle, and it's a straight line. So if we want to do any kind of ablation, and there is an accessory pathway here, I can put a catheter here and heat up, and I can damage this accessory pathway and ablate it. But right side, if you look at the right side, it's kind of folded like this. That's why if there's an accessory pathway and I ablate here, I'm actually far away. That's why the right-sided accessory pathways are difficult to ablate and requires more energy compared to the left side because of this folding of this junction. I don't know why this folding happens, but some kind of embryology. You can see this folding. This is the right atrium, and the right ventricle is connecting, and it's folded here and producing a thicker area of tissue. So the cells itself, you know, that myocardial cells are different from muscle cells in a way that muscle cells are individual muscle cells, and they are stimulated by the nerves. Myocardium is syncytium. That means there is a cell here, but it is also connected to another cell, and that's how they communicate with each other. And if you look at this, it's a longitudinal section. It runs longitudinally, and this is where the junction is the intercalated disc, and this electron microscopic view. Why is this important? I mean, just remember this. Look at this different structures. This is the actin filament. Actin filament, actin. This is intercalated disc, and on this side actin, and then there are connections with different kind of proteins, and we have now identified there can be abnormality of these proteins, and which can cause cardiomyopathy. And like this one, if we look at the dilated cardiomyopathy, alpha T catenin, and where is the alpha T catenin? This is the alpha T catenin. This is connecting the actin filament to this one, and this can be defective. And then there is another one, let's say plakoglobin. This one is related to arrhythmogenic right ventricular dysplasia. And so this is the plakoglobin. This is amazing that how far medicine has progressed in understanding this cellular mechanism of disease. And these are important that today we don't have any medicine, but maybe tomorrow or maybe 50 years from now, we'll be able to fix these things at a cellular level. And we have a lot of medicine that we actually have been developed after finding this concept that, look, there is a problem here. Is there something we can find to fix it? Before we just thought of the heart itself as a big structure. So please read up about these things. These are important proteins, important histological findings. And then I'm going to show you this actin filament and myosin. You all know this structure. I always loved it as an anatomy class. And this is how it contracts, that the myosin connects with the actin filament and then bends. And when it bends, so it is connected like this. So if it connects and bends it, then it pulls the muscle. And that's how the myocardium contracts. It's a really amazing mechanism. And you imagine that this is a small structure, how much force it is generating. And that force you can only feel if you ever pull a pacemaker lead out, and you can realize how strong the heart muscle is when it contracts. Now, there are different kind of myosin chains, like beta myosin, heavy chain, myosin, light chain, and there can be defect of these also, which is causing cardiomyopathy, which is hypertrophic cardiomyopathy. And now there is medicine that came out that is working in one of these sites. And so what happens with hypertrophic cardiomyopathy is that these cells are longitudinally oriented. Because these are defective in myosin, the heart cannot contract as good. And as a result, it hypertrophies. But when it hypertrophies in a disorganized way, and it becomes a substrate for cardiac arrhythmia. So electrically, if we look at electrical system, you know the action potential. I'm going to focus on the sinus node. look at this sinus node action. It's kind of sinusoidal. There is no sharp point. But if you look at the ventricular action potential, you can see it is sharp. And then it comes down to baseline. And once it comes down to baseline, it's straight. What the difference is that ventricular action potential, you have to trigger it with some kind of stimulation. And once you stimulate it, you develop the action. If there is no stimulation, there will be no action potential. That means this ventricular tissue will not contract without a stimulation from somewhere. On the other hand, the sinus node, and also to some extent AV node, has the potential to generate its own impulse. So it keeps going, and then once the action potential changes, it again changes in electrical activity, and then it goes and beats again. So this is the fundamental difference between these two tissues that sinus node, AV node can generate. And some of the tissue in the Purkinje can also generate its own impulse, but not as good as the sinus node and the AV node. So this is the what it is that cells have more sodium outside, potassium inside. And how does it do it? There is a ATP-dependent sodium pump, which pumps sodium out and potassium comes in. So 3 sodium goes out, 2 potassium comes in exchange. And there is also another kind of exchanger, which is called sodium-calcium exchanger. That means sodium comes in, calcium goes out, or the other way around. So this part is these two ions are controlling it. And what are these pores? These, if you look at this, 3 sodium again, and then potassium and sodium and calcium, calcium moves against gradient, and the driving force is the sodium going this way. So this slide is important. If you look at this slide, that this is the action potential of the sinus node. There is the action potential. It comes back to depolarization, repolarized state, and then it continues going up until it reaches the threshold potential to do it. And this is done by inward current, what is called funny current. And that funny current is potassium dependent. And there is a new drug called ivabradine. It is available in Bangladesh, and it works here. So people always ask me, can I use ivabradine to slow heart rate in AFib? You cannot, because ivabradine works in this current. It has no action on slowing down the AV node. So ivabradine should not be used for patients with other kind of tachycardia. It is exclusively designed to work for sinus cardia. Ivabradine is not going to work for supraventricular tachycardia because that's a re-entry mechanism. So it only works on the funny current. It's a wonderful medicine for patients with inappropriate sinus tachycardia or patients with cardiomyopathy whose heart rate remains 80, 90, or 100 despite maximum beta blocker. Let's say there is a patient whose heart rate is 100, blood pressure is 100 systolic, and you cannot go up on the beta blocker. You give ivabradine, and patient has cardiomyopathy, you give ivabradine to that patient, the heart rate will come down, and a lot of these patients are going to feel better. But ivabradine should only be used after we have maximized the maximum tolerable dose of beta blocker. But it's a great drug. Look at the action potential of the ventricular muscle. You put a stimulation in, sodium goes in, and then potassium keeps coming out and balances out, and it gets it's depolarized and repolarized state. And then there are phases: phase 0, phase 1, phase 2, phase 3, phase 4. So this is a cell membrane. You remember from the anatomy class, I don't know if you remember it, but we did. It's a bilipid layer. This is a cell membrane, and there are holes in it guarded by gates. Like here, the gate is closed and the gate can be opened. It's a unique mechanism to think about these structures at a cellular level. Is amazing that how these cells are working. And then what happens? Interesting that look at this gate. This gate is closed. This is the bilipid layer. And then for some stimulation, gate opens up and electrolyte comes in. And there is a temporary gate which deactivates it until finally closed. a resting state. And from the resting state, it will only open when there is a stimulation. So it will close up, open up, and then close with a temporary gate, and then become a resting state. That's how this keeps going on. Now, look at this interesting slide, that there is a sodium channel. This is open. And where the lidocaine is working is over here. So there is a specific location where the lidocaine works on sodium channel. Now, look at this calcium channel. Calcium channel, there are different calcium. Diltiazem works in this location. Nifedipine works in this, and verapamil works in this location. And it may explain their difference in action. That if you know that nifedipine is mainly an antihypertensive, diltiazem can actually cause blood pressure control, also cause heart rhythm problem control. Verapamil is stronger heart rhythm problem control medication plus an antihypertensive. So it's the location. It's a basic science, and I'm sure some of you will work at a cellular level at one time in your life, or maybe build up as a career, because Bangladesh is reaching a phase that we will need basic scientist physicians, and you will probably study these things. So what is the mechanism of cardiac arrhythmia? I'm going to go to a different slide. I'm going to stop here. And if there is any question, I'll go answer. Any question?
Sir, it might sound a bit stupid, but my question is, these calcium channels, sodium channels, and these channels are present in all cells, not only in cardiac cells. So
yes,
when we block the sodium channel or calcium channel blocker, the impact should be everywhere, in every cell. So
yes.
how does it specify? Is there any other mechanism?
Yep. So the question is, it's a very interesting question, that if you look at verapamil, it causes constipation. So it's not that we have got rid of, like if you take amlodipine, it doesn't cause constipation. Diltiazem doesn't. So they have, I think these drugs have been designed to be specific for specific receptors. Like as I showed you, that even the calcium channel blockers, they don't work in the same location. So yes, there is some, I mean, that's why we develop side effects from the medicines. As I mentioned, the side effect of verapamil is constipation, because it affects the gut muscle.
Sir?
Yeah.
So Rafique bhai,
Yeah.
may I add something on this issue?
Sure, please do.
Because the is going back to Guyton's physiology book, the depolarization and repolarization properties for the cardiac cells are different from the intestinal. So, and also even for the SN node and AV node versus the myocardial fibril is not the same. So therefore the effect also for the drug when we use in therapeutic dose is not going to be the same on the SN node, where the SN node is the target for the drug, or AV node versus myocardial cell compared to other cells. So it has huge sort of implications in a way that is a pharmacodynamic effect, the individual cell properties, and also the pharmacokinetics of the drug, if we need to look at the overall outcome from a drug administration.
Thank you. So think about a drug like lidocaine. Lidocaine stabilizes the myocardial membrane, but it also works on the brain. Same as magnesium we use for torsade, but it is used for eclampsia because these are membrane stabilizers. So, but they're a little bit non-specific. Secondly, depending on the dose of the drug, how much are you using? Is this big enough to affect the other cells in the body? Thank you. Any other question?
Sir, there is a very popular term, junctional. Actually, what does it mean, sir, from your anatomy?
Oh, junctional means area happening from AV node area. So any tachycardia that is happening in the AV node area. But if you look at true junctional rhythm, from electrophysiologic standpoint, should be something that's an automatic tachycardia. And that's more common in children than adults. And if it happens mainly after cardiac surgery in children, their AV node becomes the dominant pacemaker. It overrides the sinus, and they can develop junctional tachycardia. On the other hand, people use it also as a blanket term that if we cannot see a P wave, people use, oh, I cannot see a P wave, it's a junctional rhythm. So it's a broad term that is used, but to be specific, it has to be a junctional tachycardia, but that we can only define by electrophysiology study. Thank you. So basic mechanism of arrhythmia. So this is patient with sinus rhythm, and then as you can see, it develops a tachycardia. And the morphology of the P wave, if you look at lead V1, positive, negative, it changes, becomes a positive wave. So that distinctly, it is a different rhythm, but supraventricular rhythm, most likely an atrial tachycardia. And why did it happen? There can be enhanced automaticity of a focus. There's a focus which is dormant, like this is two action potential far apart, and you can make it faster for whatever reason. And I'm going to come to this. You remember that sinus node action potential that I showed is a little bit of sinusoidal wave. This is normal. If I make the threshold here, that means move it to negative, the action potential will come earlier and the rate will be faster. I can also change the threshold of this. I can make the whole thing up, decrease membrane diastolic potential, and that will reach the threshold faster. And I can do it like if I give sympathetic drug, adrenaline, this is what is going to happen. Or we can change the slope of this whole thing and make it faster. So look at this, what happens that this is the action potential of the sinus node, and if we give parasympathetic stimulation, the membrane threshold, resting membrane potential goes down, and it takes longer time to reach the threshold potential, and we get bradycardia. Reverse will happen if we give adrenaline, that it will move it up and we'll reach the threshold earlier. And so this is basically almost like physiological effect on automaticity, that I'm running, my heart rate goes up. But there can be pathological. So this is the example of physiological enhanced automaticity, a patient with sinus tachycardia with heart rate of 123 beats per minute. Now, what happened to this one? What kind of mechanism is this? We can have an abnormal enhanced automaticity, like supraventricular premature beat can happen because of enhanced automaticity, ventricular premature beat, lot of atrial tachycardia, and certain ventricular tachycardia, like RV outflow tract, VT, LV outflow, they can be of an automatic focus. And it's important to understand it because when you do ablation, we have to find the spot because it's automatic focus, and we can map it and we can ablate it. And if it is really an automatic tachycardia, it will basically, if we can pinpoint the location, we can ablate it. Now, how about this one? Anybody from the audience can tell me what this arrhythmia is? Can we get somebody to tell me what it is? Tushar?
Looking at those two streets.
No. I want from the participant, not you.
Okay. Sir, better you give choice because Dhriti Das, Dr. Dhriti Das, can you please tell? Kamal bhai, make her audible, please. Dr. Dhriti Das.
R1T phenomenon, tot 60 point is.
Okay, that's great. But so what do you think is the mechanism?
R1T, early repolarization.
Okay. So your choice was R1T. Yes, that's an option because there is a T wave here and there is an R and that produces arrhythmia. But it is also a long QT interval. So, thank you. So, what happens when we have long QT, we can develop early after depolarization, and that can produce arrhythmia. We can also get delayed after depolarization. These certain drugs can do it. This is another mechanism. And with long QT, it is early after depolarization. What happens when the QT is long? You can see this thing, and if this is big enough, it produces arrhythmia. Exactly that's what's happening with this. That look at this one. That this is happening. There is a over here. There is one notch. Nothing happened, but the next one big enough to produce this arrhythmia, and it stops. It starts and then stops. Why it starts that? Because it's changing the morphology, and it's a self-terminating arrhythmia which almost looks like VR. So after depolarization is a mechanism, and it can be delayed or early after depolarization. And so it can be, this after depolarization can happen in phase 2, phase 3, and if it is in phase 4, that becomes delayed after depolarization. Interesting, look at this. This is calcium current dependent, and this is potassium current dependent. So it's fascinating that how two different kind of after depolarization early, one is calcium current dependent, one is potassium current dependent. And now the delayed after depolarization, early after depolarization is torsade, long QT arrhythmia, and delayed is a common example is digital toxicity, which produces the atrial tachycardia. This is the commonest one. And reperfusion arrhythmia is delayed after accelerated idioventricular rhythm after MIs and some form of, and the other one that is catecholaminergic polymorphic ventricular tachycardia, that is delayed after depolarization. And then, of course, the other mechanism that we get arrhythmia is reentry. This is reentry is the commonest arrhythmia. If we take a piece of tissue, this is the tissue, it's a hole inside, and if we put an electrical stimulation, it was initially done with jellyfish, early 1900, and you put an electrical stimulation here, it will go both ways. And then at the end, they will collide and extinguish. Nothing will happen because they're colliding with each other. However, if I put a pressure over here, that means I'm creating a block here, and then put the stimulus, the stimulation cannot go this way. Just a mechanical pressure can do it. And this is interesting. Look at this. They did it in early 1900 to prove this theory. And then once the electricity has started moving this way, take it off. And once you take it off, there is an area of tissue which is excitable, and it can keep going round and round and round and round. And that's reentry until we stop it. Either it stops spontaneously or we stop it by some medication. This is an example of ventricular tachycardia, which most likely is reentrant tachycardia. I'm not going to go into details of this. Now, the reentry can happen because of an anatomical barrier. And what it means, let's say there is a myocardial tissue which gets infarcted here, and you can get reentry around it. Or you can have a functional barrier. What happens? Initially, there is a stimulus which enters this tissue and makes the whole tissue refractory and it acts like a dead tissue, and the reentry goes around it. And this is a functional barrier. And this is the example of scar-related ventricular tachycardia. So there is myocardial infarction-related scar, and the electricity can go around and then go through a slow connection and then exit, produce the QRS complex. And most of the drugs that we use, we target to make this place slow enough that it cannot conduct. Or if we do ablation, we would try to find the common area where the pathway is common and we ablate it. What happens? If I ablate it over here, the electricity will be going down this way and then continue working. So that's the tricky part of doing ablation in this patient, that you find this common exit point and ablate it. There can be other kind of reentry. It can be bundle bunch reentry like this one. electricity can go down through the right bundle, and then come back through the left bundle and produce a tachycardia, which looks like left bundle morphology or other way. And we can see this kind of arrhythmia in patients with dilated cardiomyopathy. So the QRS complex will look like typical left bundle branch block, but it's actually a reentrant ventricular tachycardia. And the other form of reentry can happen in supraventricular arrhythmia, which is very, very common. And in Bangladesh, our focus should be these arrhythmias, because there are literally thousands of these patients in Bangladesh waiting to be ablated. And this is a cure. So it is important that we take care of this group of patients. So this is an arrhythmia. Can somebody tell me what this is?
Requesting other participants except Dhiti Das, someone else, so we can broaden the horizon. We request participants to comment on this ECG. Already one participant has commented on the ECG earlier.
Tushar, anyone participant?
সেটাই বলছি।
Sudhir?
I request Dr. Naim Hassan. Dr. Naim Hassan, can you please tell the ECG?
Sir.
And please give your
what is this?
Yeah. Then tell the ECG. আপনি কোত্থেকে এসেছেন যদি বলেন।
আমি ডক্টর নাইম, রানীশঙ্কর উপজেলা হেলথ কমপ্লেক্স থেকে বলতেছি।
Oh, good. Thank you for joining us.
ঠাকুরগাঁও?
জি স্যার। Okay. জি স্যার, ঠাকুরগাঁও।
Good.
This is 12 lead surface ECG with proper lead placement. Here heart rate is around 280 beats per minute, and regular narrow complex tachycardia. I don't see any distinct P wave, but there are not after the QRS complexes. So my diagnosis, ECG diagnosis is this is supraventricular tachycardia, most likely AVNRT.
Oh, fantastic. So that's wonderful. So the rate is not 280. I'll give you a simple way of doing it. So 2 boxes would have been 150.
Yes.
Little bit less than 2 beats, so it would be like 170, 180 beats per minute.
Yes,
but
sir, yes.
Your observation is excellent. There is something after the QRS complex. And even if you could not see anything, the most like if you look at lead V3, you cannot see any P wave. But if you see lead V5, there is a notch. In V2, maybe there is something which normally you should not access. So this is AV node reentry. Absolutely. So AV node reentry, what happens is that there is slow pathway in the AV node and the fast pathway. Electricity can go down the slow pathway, and then it blocks in the fast, but nothing happens. It takes a long period. But if the electricity goes down the slow pathway and come back to the fast pathway, and the pathway is now open, it can go round and round. So it will come back through the fast pathway and go round the slow pathway slowly and come down to that. Because the AV node is in the middle, P and QRS complex is happening at the same time. And that's why you will not see the P wave. Or even if you see it, you will see either immediately before or immediately after the QRS complex. And that's the typical example of AV node reentry. Naim, thank you. So this is another one example of reentry. This is a narrow QRS tachycardia. If I imagine there is a P wave in the middle. So this is a patient with WPW syndrome. You can see clear pre-excitation. What happens with these arrhythmias? That electricity goes down through the AV node and comes back through the accessory pathway and then produce this narrow QRS tachycardia. So this is a macro reentry circuit. If it goes other way around, then you will get wide QRS. But because it is going down through the AV node, the QRS complex is going to be narrow. This is an example of atrial flutter. You can see the typical sawtooth appearance. What happens with atrial flutter? There is re-entry in the right atrium. If you look at this inferior vena cava, and here is the tricuspid valve, imaginary tricuspid, there is a narrow corridor. And in that corridor, the electricity can go down, and typical flutter is always going around this. Interestingly, we have mentioned this before, typical flutter is not very common in Bangladesh. I do not know why, but in America it's very common. European countries also very common. Also, I talked to doctors in Japan. They don't have that many flutter patients, but they have more fib. In Bangladesh, it's the same. But if there is typical flutter, we can do ablation, and this is almost like a cure for typical atrial flutter. There can be another kind of re-entry. We see patients after cardiac surgery. If there is a scar in the right atrium, like if somebody went for atrial septal defect repair, they cut the right atrium to reach the atrial septum, and then there can be re-entry around it. And what the new surgeons do, they extend this incision to the atrioventricular junction. If we extend the incision to the atrioventricular junction, then there will be no gap and there will be no re-entry. So newer technique of surgeons, they will not do it this way. They will not leave a gap here. So this is another mechanism of, it's a macro re-entry. I think I'm going to stop here, and then we can discuss and go from there.
Sir?
Yeah.
Sir, as a mechanism, there is a term that is the brady-dependent AKD or brady-dependent VT. What is the mechanism, sir, really?
Oh, that's the bradycardia dependent is actually torsade most of the time. So if you look at
ওই আগের ECG-টা ছিল স্যার খুব সুন্দর।
This one. So what happens if you look at this QT interval? I don't have the previous R wave. There is a little bradycardia, and this QT is longer. And this is actually triggering the torsade. That's why in torsade management, if we can get the heart rate up, look at this example. This one, let me just, there is a QRS and there is a normal QRS. QT is much shorter because the RR interval is short. This one, long RR interval, long QT interval, and that produces, this is actually perfect. This one did not produce the torsade because the QT is shorter here. It's just a PVC. So this is fantastic example. Thanks for the question. So this is bradycardia dependent torsade. And that's why in patients who we give sotalol, we try to avoid significant bradycardia because then they can predispose them to torsade.
So, sir, this is basically direct after depolarization.
This is early after depolarization.
Sorry, early after depolarization.
Early after depolarization.
This brady-induced VT is because of the early EAD.
Early after exactly.
Sir, is it the same, sir? The long pause, short pause can maybe the mechanism for the arrhythmia?
Oh, that is different. That long short sequence during electrophysiology study, that we do to create a gap in the conduction. So if there is a substrate which is slow conduction, fast conduction, sometimes we can use long short sequence to induce VT. That's just a technique to create a gap between the induction of tachycardia.
Now, I have one comment on that about the use dependency. Sure. And also it depends on the binding of the drug, whether it's higher heart rate or lower heart rate, okay? And the reverse use dependency in the sotalol type drug, they bind more when the heart rate is lower. that can cause prolonged QT and can cause EAD early after depolarization. On the other hand, use dependency, there's like flecainide or class 1C drug. We call pocketing the pill when they bind better and even can terminate the tachyarrhythmia. So they work better when there's tachycardia. So, binding of the drug and higher heart rate, lower heart rate is also important in this type of situation.
All right, thank you. Any question from the audience, attendees? If not, then I think the talk should end here, and anybody wants to say anything.
What is LVOT-VT?
Oh, LVOT-VT, basically anatomically. So you can get ventricular tachycardia from the RV outflow tract, or you can get it from LV outflow tract. And most of these are automatic tachycardia. And they can be treated with medicine, beta blockers, or you can ablate them if you can map it. Yeah. And interestingly, a lot of the VT that we used to think of as RVOT are actually LVOT, because if you look at it, that RV outflow tract and the LV outflow, they sit very close to each other. And that's why the confusion happened. But now we have algorithm. If you look at the ECG, 12-bit ECG, from lead V1 to V6, and the leads are properly placed based on where the R wave transition is, you can more or less predict, is it an LVOT-VT or RVOT-VT? Thank you.
Sir?
Yeah.
Sir, we have got experience of some of the patients' experiences very frequent or satisfied, very frequent, clinically in the ward or the CCU. We see there are some patients. Sir, what should be the actually appropriate medical management at that time? So very frequent or satisfied is.
Oh, so the patient with very frequent, so you have to look at the electrolytes, number one. Number two, is there any offending drug? And the offending drug can be an antibiotic, because let's say the patient comes with sepsis and you start a new antibiotic, and that can be the cause. And then, of course, let's say somebody is already getting in and out of Tarsad. First of all, you stop the offending medication, try to keep the heart rate up. You give magnesium, even if the potassium is, magnesium is good, because that stabilizes the membrane. And those are there is no role of antiarrhythmic drug in this situation. And if you, the way to keep the heart rate up, you can give isoprenaline IV, or you can put a temporary pacemaker in, keep the heart rate up until the offending medication has washed off. And most of the time it will.
Thank you, sir.
And Rafique bhai, one of the other trigger is the ischemia.
Yeah.
And if we don't have any immediate cause, like drug-induced long QT or electrolyte imbalance, hypokalemia, hypomagnesemia, and the patient is not young and qualified to have CAD, then we need to be vigilant about ischemia triggering polymorphic VT.
Yes.
And in that case, anti-ischemia is the most powerful antiarrhythmic.
Sure.
But one thing, Rafique bhai, the LVOT or RVOT tachycardia, if we go back to the mechanism, then what will be the most likely mechanism in most of the VOT or RVOT tachycardia? VT.
Automatic focus.
Yeah, exactly.
Because when we do ablation, we do single. So what happens? Let's say there is a scar-related VT. We try to map the circuit, but in LVOT, RVOT VT, because it is automatic, it is coming from a specific point, we try to map it to that point and ablate, and it works. And the other thing that happens, when you do the ablation, initially there is an acceleration of the VT, and that tells you that you are on the focus because it accelerates. So it's an automatic mechanism, and hence automaticity.
It's a very important issue in the board exam, because they also give the option for ICD, which is the answer. It has their choice is the ablation.
Tushar.
Thank you very much, sir. And though it's quite a long gap, but again, we are rejuvenated by the excellent lectures from Professor Rafique Ahmed, sir. And I'd like to request Abdul Chowdhury, sir, to say his remarks on this lecture and conclude the session. Wadud, sir.
Hello.
Hey, Wadud bhai. We can listen.
Sorry, এটা off করে দিবেন?
Yes.
আমার মনে হয় যে স্যার যেটা প্রপোজ করেছিলেন এবং দেখিয়েছেন যে আমাদের কিন্তু যে বেসিকটা কেন হচ্ছে কি হচ্ছে, আমরা যে ওষুধগুলো ব্যবহার করছি কোন জায়গাটা কি কারণে ব্যবহার করছি, এই আন্ডারস্ট্যান্ডিংটা আমাদের কিন্তু আস্তে আস্তে ক্লিয়ার হওয়া উচিত। এবং যেহেতু এরিথমিয়া এমন একটা জিনিস এবং এখন যেহেতু একদম টার্গেটেড থেরাপির জন্য ওষুধ তৈরি হচ্ছে, আমাদের এই সেলুলার মেকানিজম গুলো আন্ডারস্ট্যান্ডিং করাটা সময় চলে আসছে। এক সময় ছিল এত জরুরি ছিল না, এখন কিন্তু সেটা আমাদের বুঝতে হবে যে কোন জায়গাটা কি ওষুধ কেন দিচ্ছি এবং কি প্রবলেম হতে পারে। এই যে আরেকটা যেটা দেখুন কথা শেষের দিকে এসেছিল যে এরিথমিয়ার ক্ষেত্রে খুব একটা ইম্পর্টেন্ট জিনিস হলো ড্রাগ ইন্টারাকশন, এবং সেক্ষেত্রে ইলেকট্রোলাইটে কি রোল আছে আমার মনে হয় এর পরবর্তী লেকচারগুলো যখন আরো স্যার যাবেন তখন কিন্তু দেখাবেন কোন ইলেকট্রোলাইটের ঘাটতি বা বেশি থাকার কারণে কি ধরনের প্রবলেম হতে পারে, আবারও সেই সেলুলার মেকানিজমের কথাটাই আসবে। এবং সেক্ষেত্রে কোন ধরনের ওষুধটা তাকে ভালো কাজ করবে আমাদের কিন্তু সেটাও ওখান থেকে আমরা আন্দাজ করতে পারবো। কাজে ব্লাইন্ডলি একটা ওষুধ দেব এখন কিন্তু এরিথমিয়া ট্রিটমেন্টে সেই জিনিসটা কিন্তু গ্র্যাজুয়ালি উঠে যাচ্ছে। আমাদের কিছু কিছু জিনিস সবসময় মুখস্থ করতে হয়, ইমার্জেন্সিতে আমরা ড্রাগ এটা ইউজ করবো ব্রড স্পেকট্রাম অ্যান্টি এরিথমিক, কিন্তু এরপরে এই টার্গেটেড থেরাপির ব্যাপারটা আমাদেরকে আরো বেশি সচেতন হওয়া দরকার। স্যার আজকে এটা সূত্রপাত করলেন, আশা করি আমরা কিন্তু আরো শিখবো এইভাবে। স্যারকে অনেক ধন্যবাদ এই জন্য।
Thank you.
Tushar, our next lecture on the 30th, sir, এই মাসের 30 তারিখে, এবং সেদিন আমাদের স্পিকার হবেন আমাদের চৌধুরী হাফিজ ভাই। 30th.
Okay. তো দেখা হবে সবাইকে। শুভরাত্রি।
Sir, and we will continue the program as such. Hopefully, this will help our participants, and the senior teachers also gets benefited from these lectures. And again, thanks to our scientific partner, Bexnoco Pharmaceuticals. Thanks all, and we will meet again on 30th July.
Okay, bye bye.
আমার হয় কামরুল এবং নাবিলাকে আলাদা করে থ্যাংক ইউ দেওয়া উচিত।
Thank you, Wadud bhai.
Thank you, sir.
আসসালামু আলাইকুম।
Welcome, sir.